Ladies and gentlemen, a very good afternoon. This is your 2-minute warning. 2 minutes. Showtime. Curtain goes up in 2 minutes. Ladies and gentlemen, a very good afternoon. Welcome to Capitol Hill and welcome to the Ways and Means Committee room. This is it. This is the arena. This is where big ideas come to be debated, which is the perfect setting for our Pathway series. I'm Aaron Bean. I have the honor of representing the First Coast of in the free state of Florida, the greater Jacksonville area. I serve on the Ways and Means Committee, and we have a problem. Our country is now $39 trillion in debt. And if we're going to solve the debt crisis, we have to solve health care. It's the one thing that Republicans and Democrats agree on. Health care is not where we want it to be. It's expensive, it's unsustainable, and it's not getting us the best results when we compare ourselves with other civilized nations. So how are we going to do it? What are we going to do? We have to build consensus, and that's the origination of this series, of the consensus series. In just a few minutes, Mary Mayhew will be up here. She's one of my colleagues from the free state of Florida, and I was in the Florida legislature for a long time, and it turns out the state legislatures offer a more robust forum for debate. Sometimes on a federal level, there's the 5-minute clock right there. 5 minutes. You've got 5 minutes to make your case. You've got 5 minutes to interview any witnesses, and before you know it, lickety split, that 5 minutes is gone. So a lot of times we don't get the chance to flush out the best idea or debate what could be better. Convince me I'm wrong, and let's make a better plan together. And that's the origination of this. So we've put together all-star panels, think tank heroes, very smart people in their fields, as well as people who know the game real well, in the hopes of bringing them together to have an old-fashioned Lincoln Douglas debate and idea raisers where we can go forward. So today in healthcare, a couple of hot topics that you wanted. And we want to thank I know we have hundreds of people now watching right now. So welcome. We're glad to have you here. If I'm on your laptop, you're on Capitol Hill Live. So some topics today that we're going to discuss, billing and utilization. Billing is important because this has come as a shock to many of you. There are bad people that wish to bill us where they didn't provide any services. So how do we have a system that we trust and go forward and bill? And whether or not you're in network or not network, that's something that we're going to discuss. You'll say, Congressman Bean, didn't we already handle that bill? Wasn't that the no surprise bill? Didn't we already do it? Isn't that already settled? Well, it turns out the no surprise bill has a surprise. It's not working in many instances in terms of the dispute resolution. We'll talk about that. We'll also talk about utilization and what's something called prior authorization, where health insurance companies will tell you it's an important system to make sure that we manage costs. Providers will tell you, well, wait a minute, it's just an extra obstacle in terms of getting the care that our patients want and need, and getting in between the doctor and the patient. So we'll talk about that as well. We've got two all-star panels teed up for you, ready to go as we have a big clash of ideas and thought and debate. But first, we got a little bonus surprise for you, a little something extra. And it is one of my great friends who also serves on the Ways and Means Committee. And it turns out that he and I share a passion for fixing healthcare, for improving healthcare and making it better, as well as making it sustainable. If you haven't Googled him and some of his 5 minutes, that's what I go to watch, and his 5 minutes on commentary on our current system. But from the great state of North Carolina, would you please welcome for a couple minutes to give us his thoughts on building that consensus? It's Dr. Greg Murphy.
If this doesn't work out, you've got other careers ahead of you. So anyway, thanks, guys. I'm not going to talk long. Let me just frame the conversation just so everybody knows what no surprises mean. I'm a urologist, so I treat a lot of kidney stones. Say somebody's traveling from West Virginia and they end up in my neck of the woods, and they have a terrible problem having a kidney stone. They come in the emergency department, have to be operated on. We operate on them, get them better, and then send them home. But I was out of network, the hospital was out of network, the anesthesiologist was out of network, the radiologist was out of network. So all those other people did not have a network, were not in this gentleman's or lady's insurance plan. So what they do, they get this bill that says, oh, well, I thought I was in network. No, that's not. You're not in network. You are getting a surprise bill. And there have been some real problems with this as far as some of the charges that patients got. So in 2019, the No Surprises Act came out. And the whole purpose was, the entire purpose was to take the patient out of the equation so that they don't get these surprise bills, and let those who provide the care and those who pay for the care work on trying to work and get a settlement. And so what does that mean? All of a sudden, we've had a lot of claims that go into the process, the independent resolution process, to try to figure this out. Sadly enough, it was a bill that was passed in the House. Then it was passed in the Senate, signed into law by President Trump. It went over into the Biden administration, and instead of being right in the middle, they took this all of a sudden to one side. It took 5 lawsuits from the Texas Medical Society to try to pull it back. The problem is now it's not working. There's no teeth in this arrangement. So we have two sides of this, and if anybody knows me when I talk about healthcare, and I've said this many, many times, I'm an equal opportunity offender. I'll go after any facet of what I believe is in our healthcare system. I still practice, so I still see patients and hear about these things. I will go after any facet that I believe is not being diligent and responsible in healthcare. On one side, we have insurance companies that have had judgments adjudicated to them in the IDR process, and they are keeping hundreds of millions of dollars that has said, look, you're supposed to be paying these, paying the physicians of the hospitals, and they're just sitting on them, not paying it. On the other side, we have some physicians, and I'm a physician, I'll point them out, who are now doing things when they shouldn't be, putting people outside of network and gaming the system. When you have one person that says, all right, I charge for, a wrist fracture, and they charge $300,000, which is ridiculous, but the insurance company offers $1, the IDR process does not allow them to adjudicate that. They have to pick it, one or the other. So you have a bad number here, way too much, and then way too little. This needs to be fixed. I actually have legislation to try to bring things together where if you're not paying on the insurance side, it's $10,000 a day after 30 days you're not paying. On the other side, if you're a physician and you're not doing the right thing, you get the same penalty also. The whole purpose of all of this is to bring everybody into the network. You shouldn't have people out of network. We should have insurance companies paying for care appropriately, and we should not have people charging too much for care appropriately. So this should be a great discussion today. The whole purpose, again, is to try to bring people together to keep as few people and few services out of network as possible. So thank you, Mr. Bean, for having this great discussion. Look forward to hearing more about it. Thank you for inviting me.
Thank you, Doctor. Appreciate you very much. I know we're talking about bringing you back as a panelist or a moderator and being a part of this consensus. So thank you so much. So let's get to the Surprise Billing Act. We've got a great all-star panel, and our moderator will introduce our panelists. For our moderator, we went back to the well. We had great success with this gentleman who has moderated in the past. The numbers are in, and he was a popular pick to lead us today. His name is Shane Woods. He is the VP at Alpine Group Partners. He was a fixture on the Hill for many years, having both served in the health policy arena for Senator Tim Scott and for Representative Gus Bilirakis. Ladies and gentlemen, moderating our first panel, please welcome Shane Woods.
All right. Well, thank you so much, Congressman Bean. And I believe what he meant to say actually was bottom of the barrel. But nonetheless, I'm glad to be back. Thank you so much for having me. As Congressman Bean mentioned, we are very, very excited. I think we've got, again, a really all-star panel. And that wouldn't have occurred today if it wasn't, of course, for the good Congressman's leadership and that of his staff as well. So thank you, Congressman Bean, for your continued commitment to consensus leadership and, again, for your staff's hard work to provide this great platform for us today to have a substantive discussion. As we heard earlier from Congressman Murphy, the No Surprises Act was one of the most significant bipartisan health care laws enacted in recent years. And there's broad agreement that patients shouldn't face devastating, unexpected medical bills. The debate now, however, is less about whether the law's goals are right and more about whether the implementation and specifically the dispute resolution framework are achieving those goals efficiently, fairly, and sustainably. So today's conversation is an opportunity for all of us not to just identify those points of friction, but to explore where practical consensus may exist for Congress moving forward. I can feel it coming in the air tonight. Consensus. That's all that I have, Congressman. But in any case, with that, let's go ahead and introduce our panelists for today's conversation. So we're going to start here on my right, your left. Ariel Baywitz. Ariel is Vice President of Health Economics at Elevance Health, responsible for the analytics that enable Elevance Health Solutions functions. His focus is on network, including reimbursement analysis, provider profiling, and value payment model design, as well as clinical risk stratification and targeting. Over his 20 years with Elevance Health, Ariel has had roles in network strategy, patient innovation, and analytics that span both network and clinical domains. He has chaired the company's price transparency strategy, architected Elevance's national value-based care payment model, built the platform that administers its VBC contracts, has developed an enterprise provider profiling solution. He also holds two U.S. patents in high-value physician referral and network design. Pretty smart guy. Ariel currently leads the enterprise strategy addressing rising costs tied to the No Surprises Act and the Federal Independent Dispute Resolution process, leveraging his expertise in health economics and provider reimbursement. Holds a Master's of Public Health from Columbia University and a Bachelor's of Arts from Yeshiva University. He's been with Elevance Health since 2005. Thank you so much for being here. Garrett Hoimer, he joined the business group on health to lead policy and advocacy in 2021. Garrett has, with the business group on health, they are a leading nonprofit organization devoted exclusively to representing employers' perspectives on critical health, well-being, and workforce strategy issues. Prior to joining the business group, Garrett held in-house government relations and legal roles and was an attorney in private practice with a boutique benefits, labor, and employment firm in the windy city of Chicago. Patrick Valicki, we're going to go all the way on the other side here, serves as Halo MD's Chief External Affairs Officer and SVP of Government Affairs, leading all government relations and strategic communications efforts there. Patrick brings nearly 20 years of experience in government, healthcare policy, and advocacy, although you don't look like it. So I don't know. It's the beard, maybe, skincare routine, whatever it is. Let me know after this. Including senior legislative roles in both the U.S. House and U.S. Senate, leadership at a major hospital trade association, advocacy on behalf of 2 Fortune 50 health insurers. Most recently, he was an SVP of Government Affairs and a member of the senior executive leadership team at Envision Healthcare. He's currently a member of the board of directors for the Emergency Department Practice Management Association and the immediate past chairman of the board of the Emergency Medicine Policy Institute. And last but not least, Dr. Adam Brueggemann. He's the chairman of IndyMed, a physician-led advocacy organization, is a board-certified orthopedic spine surgeon at the Texas Spine Care Center in San Antonio. Before earning his medical degree at the University of Texas Health Science Center, and completing his residency at the University of Florida. There you go, Florida connection right there. Dr. Brueggemann received a master's degree in hospital administration at Trinity University. In addition to previously serving as the president of the Texas Orthopedic Association, he's held national leadership roles, including serving as a resident representative for the Association of American Medical Colleges and on the academic leadership committee for the American Orthopedic Association, where he was also a member of its Emerging Leaders program. So again, we got a lot of brains in today's room. Sans your host. So again, thank you all for being here and for your participation today. So let's jump right in. Before we get into the areas of disagreements, which I promise my audience there will be some fireworks, I'm sure. Can each of you guys briefly identify one thing the No Surprises Act unquestionably got right for patients? So let's start here with Ariel, and we'll just kind of work our way down.
Get this right over here. First, I want to thank you, Shane, and thank you, Congressman Bean, for bringing us here. It's really a pleasure to talk about an issue I think we all feel very passionately about. I'm sure we're going to disagree to your point somewhat, but hopefully we can all reach consensus on things that matter, such as patient safety and patient protection, as well as healthcare affordability. I do want to just hit a little bit on what Dr. Murphy said and just bring it back a number of years to when people used to get surprise medical bills. And talk a little bit about the No Surprises Act, which really did 2 things. The first thing, which I think got right very well, is the idea that we should limit how much money a patient pays when they see a provider that they had no choice around. And so Congress basically created the concept of a qualified payment amount, the QPA, which is essentially the median in-network rate. So it's the midpoint of what in-network physicians are paid. And the idea there was, if you are a patient and you do not choose to see an out-of-network physician, you shouldn't be responsible for paying more than what a typical in-network physician is paid. And I think that idea makes a lot of sense, and that actually has worked very well. We don't hear as many, we don't read newspaper articles about all of these surprise cases as we used to, and certainly many of us have experienced that as well. I think what hasn't worked as well is what we're going to talk about, which is the arbitration process, the IDR process. But the first piece, I think, has worked well, and we just need to maintain that. Great. Garrett?
Thank you very much, Shane. I appreciate it. And I want to say for the Business Group on Health, thank you very much, Congressman, for inviting us and for hosting this. It's a great discussion. I will add on to what Ariel said, because I think the clearest win here has been on behalf of patients and taking them out of the middle. I know for employer plan sponsors, we would design our plans preferring that folks use in-network providers, and often providing out-of-network coverage, but ultimately being beholden by and limited by the terms of the plans with regard to how much the plan would ultimately pay for that out-of-network service. Because otherwise it would be a runaway train and it would incentivize out-of-network utilization. And what was really personally very heavy on me when I was working with plans directly was someone would go to an out-of-network provider because they were surprised or just mistaken or they preferred it, and that out-of-network provider would, bill the plan, we'd pay what we would pay, and then they would be left with the balance bill. And I was really limited as an attorney representing the plan on how I could help them and how I could guide them to address those concerns. So we were elated with the development of the No Surprises Act to really take the patients out of the middle there. And the trade-offs were we knew we were going to be more responsible and have some more administrative burden on resolving these unpaid amounts. And we were happy to do that for the benefit of our employees and their families. And we want to continue that focus.
Great. Adam?
Yeah, I think I'd like to call, first of all, thank you for having me today and appreciate the panel. It's a very, very good panel. I've had a chance to talk to everybody beforehand, either multiple times beforehand or recently. But I'd like to call it the patient shield, and that's what it's done. It's shielded patients from things that they have no control over, a dispute between a doctor and an insurance company about what's a fair payment. The patient's not a part of that. They just happen to be caught in the middle. And so this law has created a shield for them. And the shield has a value to it. $567 per patient per year is what the British Medical Journal identified was the savings to every patient. That's money that went directly into the patient's pocket. Didn't go through anybody else's pocket before it went to the patient. It went directly into the patient's pocket and spending they didn't have to spend. And we're saving about, based on the data, probably 1 million patients are being preserved from having an out-of-network bill every month, 1 million patients a month. So this is a very effective bill as far as shielding patients from the things that you've heard the two previous panelists talk about.
Thanks. Thanks, Shane. Thank you, Congressman Bean, Dr. Murphy. I think to the very point of the question, right, what we have to get right first with the NSA is protecting patients. First and foremost, that is the objective and the goal. And I think to clarify, I think some of the direction here, it is important to note that the QPA is designed to be that median network rate and that rate that the patient is held accountable to. But to say that it is the median network rate, I think is a point of very clear contention. We have so far had one audit of those QPAs, which found material deficiencies. So I think there is some very real systemic issues with some of the fundamentals around implementation of the NSA. And really, really importantly, not every patient is being protected. There are glaring instances in which there have been changes to the patient responsibility on the remittance advice documents from payers following arbitration, right, where an increase in patient responsibility occurs, which should never happen. I have close to $250 million in instances in which insurers simply failed to apply the patient protections at all and have advised physicians to bill the patient for the entire charge amount for services very clearly protected by the NSA. So I do think it is critical that we get the patient protections right first. That is where there are some serious concerns, and it's frankly one of the most important things that Dr. Murphy's legislation, the NSA Enforcement Act, could go a very long way to correcting.
So, Patrick, I'm going to have you keep your microphone, and then we're just going to work our way back this way, kind of doing a snake pattern here. Now that we're a few years into implementation, what does success look like from your perspective, and where do you think Congress would be surprised, there's that word again, surprised, to learn the law is not functioning as intended?
So I think first and foremost, success looks like, again, patients being protected first. But second, we've seen the law fail to achieve one of its other primary purposes, which is to encourage in-network arrangements following arbitration. That was always part of the design. The IDR process is expensive and cumbersome on purpose. That is a feature, not a bug, because it is supposed to be more painful to go through arbitration for either party than it is to simply reach an in-network arrangement related to where that economic equilibrium through IDR takes you. I think Congress will be surprised to know that some of the drivers of that are epically high rates of non-payment of arbitration awards following the IDR process, and that over 27% of the time when insurers do lose in the arbitration process, they lose by default. There is no offer submitted whatsoever. And that is leading to the process not working the way it's designed to work. A lack of meaningful participation in pursuing the actual objectives of the law are leading to outcomes that weren't intended.
Great. And Adam?
Yeah, I mean, I think we kind of discussed what has really worked well, and it's that it's that $567 back in every patient's pocket. I think that's critical and important, and that's really a huge relief given how much our premiums have risen. I mean, I'm an employer. I employ just under 50 employees in my practice. I pay those premiums on behalf of my employees, and seeing $567 go back into their pockets is meaningful. But I think what the surprise would be, and it's the No Surprises Act. We aren't supposed to have surprises, right? So the surprise would honestly be the fact that the process has one-sided penalties. And I think that's something maybe we haven't talked a lot about. We've talked about things I think all of us probably would agree on, which is, there's some issues with eligibility that need to get fixed. We've talked about non-payment issues that need to get fixed. And I think those are well known to Congress. But what we haven't talked about is the fact that when Congress wrote this law, they put penalties in place for physicians like myself. So if I don't notice and consent the patient appropriately, if I don't put the notice up in my office correctly, if I balance bill a patient, it's $10,000 to the doctor every time they fail to do that. If the insurance company doesn't calculate QPA correctly, $0. If the insurance company doesn't pay the doctor, $0. If the insurance company doesn't do what they're supposed to do, $0. It's unfair in how we did it, and I think that's honestly what Dr. Murphy, Representative Murphy, is trying to get at, is we need to balance this scale a little bit in multiple ways. One that he talked about here, but creating some form of enforcement, in which I think we'll talk about, and we'll probably have some agreement on what that looks like, is going to be needed in order to balance this scale out. There shouldn't be penalties on one side of this scale while failing to enact penalties on the other side of the scale.
All right, and let's swing right on over to Garrett.
I appreciate it. And, I think these points are well made, and I take them very seriously. And, as a given for your experience with the No Surprises Act, I think for self-insured employer plans, which are, my main constituency, I will say with respect to the penalties in particular, and like the one-sidedness of the structural penalties in the No Surprises Act itself, we already have administrative responsibilities and accountability through ERISA, which is the Employee Retirement Income Security Act of 1974, for administering our plans appropriately in compliance with the plan documents and applicable laws. So there is an enforcement mechanism under ERISA that applies to self-insured plan sponsors. So we're not out here freewheeling, is I guess my point. I want to talk about, and I would be willing to talk about, appropriate responsibility for the respective parties. I think there's we're all responding to incentives that have been put in place, and I think as we change those incentives, we will change behaviors. I think 2 points of agreement here on things that Congress might not know or fully appreciate at this point. To get to your question, is that the law is not driving in-network participation in the way that it was set forth to do and it was hoped for. We agree with that. We want to fix that. I think we have different beliefs on why that's happening between all of the stakeholders. But at the end of the day, it sounds like we all want to fix it and to drive in-network participation. And the second thing is, that we have problems with making sure that the claims submitted for arbitration are eligible. And it sounds like everybody up here agrees that ineligible claims should not get into arbitration, should not be an expense on the system for the provider side or for the plan side, and should not ultimately get a payment determination that clogs up the system and that we end up trying to dispute on the back end. So but there is a discussion to be had about what constitutes an eligible claim, making sure that you guys have all the information you need to submit the claims appropriately, making sure that we have an opportunity to review those and say, well, this one actually should be over here. And it's just a ministerial administrative process that we are hopeful that the pending final operations rule will help address some of those issues on eligibility review and determination. But I am really encouraged by hearing that we agree on these really fundamental 2 elements: the in-network driving and making sure that ineligible claims don't make their way through. I will say on the non-payment piece, we are really sensitive to that. We want to make sure that the physicians get paid for the services they provide to our employees and their families, and that payment is made timely. Again, with ERISA, ERISA's provisions apply here with respect to my plans and how they operate. So, from my members, what I am hearing is when there are instances, very, very few instances of non-payment within the period that's dictated, it's because questions have been raised on eligibility of the claim, even though it's made it all the way through arbitration. And the second factor would be just not getting consistent enough information from the IDRE, the arbitrator, upon which to make the claim. So, this is really like in the weeds, kind of boring academic stuff. But to administer a plan, you have to do the business of the plan, and you have to be able to keep the records of the plan. And we need the right reports coming out of the independent dispute resolution entities to be able to attribute the payments back to the right accounts. And there are many times, what I'm hearing, that we just don't get enough information. So we're going back to the IDREs or we're going to the CMS help desk, and that's not an appropriate remedy.
All right. And Ariel.
Great. So I actually agree with a lot of what was said. Definitely patient protection is part of what success, I think, bringing providers in network is very important. I also think aligning payments, the actual IDR awards, with in-network rates is critical, and bringing down overall costs. Hallmark, I think, of the No Surprises Act was about healthcare affordability. I think what Congress would be surprised to know is really how far we've drifted from that. So let's just start with the volume. The volume in 2025 was 2.6 million disputes, okay? That was over 100 times what federal agencies originally projected. And I think what's actually even more concerning with the volume is the nature of the cases themselves. Because when you hear the No Surprises Act, what you think of is surprise bills. The cases we're talking about before, ER cases, anesthesiologists who a patient didn't necessarily plan in advance. But what we're actually seeing is that the majority of award dollars is not going to surprise bills. The majority of award dollars actually is going to elective and planned procedures. So let me give you some stats in terms of what we're seeing. 40% of the award dollars today across our plans is going to orthopedic and spine-related services. 15% is going to plastic surgery. The number one code that we see nationally based on award dollars is breast reduction surgery, which in general is a planned procedure. And when you look at the awards themselves, again, part of the idea was that this was supposed to be anchored to in-network rates. That was the concept of even having the QPA. On average, we are seeing that awards on average are over 8 times what we pay in-network physicians. Dr. Bruggeman mentioned, how patients are saving around, $567 per claim, which is very important. We see on average, more than $7,000 per dispute is being paid out. And that's, again, the average. Let's talk about specific details, because I think sometimes people hear 8 times, and they hear, actually, in many cases, we're looking at 20, 50, even 100 times in-network claims. So sometimes people hear these numbers, and it just they seem big, but I want to make it real. So let's start in the West Coast, okay? Spinal fusion in the West Coast. Beverly Hills, Los Angeles. Medicare pays around $1,500 for a spinal fusion, which I think we'd all agree is low. Commercial payers, generally speaking, pay between $2,000 and $5,000. The average award in IDR, again, the average is $100,000. And that's the primary surgeon. In many cases, there's a physician's assistant, not even an MD, or a co-surgeon that bills exactly the same amount. So $100,000 is actually $200,000 for something that typically in-network is paid around somewhere between $2,000 and $5,000. Let's go to Las Vegas. Okay, Las Vegas, we'll talk about hernia repair. This costs, on average, commercial payers are paying around $700. Medicare pays $400. The average award that we see is $30,000. The average. A lot of physicians are getting paid and getting awards significantly above that. New York, hammer toe procedures. Podiatrists are now using IDR. Podiatrists, that was never part of the No Surprises Act. These are not surprise bills. Medicare pays around $400. The average commercial payment is something closer to $700. The average IDR award is $30,000. Okay? This is not a negotiation gap. This is inflation built into the system. And so, yes, I think the patients have been protected, which is great, but this is no longer functioning as the narrow backstop that I think we all expected.
All right, and Dr. Bruggeman, I saw you kind of reaching for the microphone there. Did you have a comment or okay? So kind of sticking on this for a moment. So first off, I do want to acknowledge we did hear the C word, Congressman Bean. We did hear consensus. We're starting to get there. Some shots fired, but I think we're getting there. But let's drill down a little bit further here. So I want to start with this side of the table. Garrett, I'm going to start with you. One criticism heard frequently is that the law, No Surprises Act, solved the patient-facing problem. I think all of us kind of talked about that issue here, but then created a new administrative litigation-heavy ecosystem behind the scenes. Is that a fair characterization, would you say, or why not?
Yeah, I think that's a fair characterization. Yeah.
Okay, and Ariel?
Yeah, I think, and we're talking about the administration, or we're talking about just shifting the costs across the system. Well, let's talk about shifting the costs. So I think, again, patients are protected. Costs, though, have not disappeared. What we're seeing is costs accelerate significantly, and the costs really have shifted from the patient to the employer. I think what a lot of people don't know, actually, is that 90% of the IDR costs are actually borne by employer-sponsored plans. So what that means is that the payers, in this case, are actually not paying these claims, these IDR awards. It's employers. We have employers, large employers, who are seeing $10 million, even $20 million in unplanned expenses tied to IDR. And those are the large employers. I mean, we have, if you think about a small employer, let's say has revenue annually of around $1 million. Think about what one of these lumbar surgeries would do, $200,000. Devastating. And I speak to employers all the time, actually, about this, and they are very afraid. This is costing them a tremendous amount of money. And what they say to me is, how is this possible? How is it possible that I have to pay $200,000 for something that in-network physicians are paid around $5,000. And by the way, in Los Angeles, most of these surgeons are actually in-network. So why am I paying $200,000? I want to be spending this money on wages, on salaries, on benefits. I don't want to be spending it on abuse. And so, in general, they supported the NSA, but the expectation wasn't that it would be functioning in this way.
I was answering the question you asked because it's an old lawyer habit of just answer what was asked. Sorry, recovering. Adding in just a little more color. I do think that the parties that are bearing the costs here, honestly, are the employer plans and the employees who are paying the premiums, as Ariel illustrated, and the providers who have a lot of administrative costs that they're going to have to bear to, that siphon out of the money that they are paid for the very valuable work that they are doing and the procedures they're doing in order to, navigate this process. And that ultimately comes back to the employer plans, but they're going to, that's coming out of their pocket as well. So I want to acknowledge that really it's the principals on both sides of this equation, and everybody else in the middle is, passing the money through and taking pieces in providing value. I'm not, throwing stones, but, that is an administrative cost out of both ends.
Okay. And Adam, just to give us the provider perspective here, do you think it's a fair characterization to say that one of the new things to kind of come out of this is this administrative burden, this litigation heavy ecosystem? Is that a fair characterization?
Yeah, and I think I agree with what Patrick said earlier. I think that's by design. I think the intent was that it should be difficult to go to arbitration. It should be easier to pick up the phone and call Elevance or whomever and say, hey, let's come up with a fair price and let's figure this out before we all have to go spend a bunch of money. And I think potentially there's an opportunity there, and I think maybe Congress has recognized this too, that the fees that we're paying on both sides of this, not counting the arbitration fees, but the fees we pay to the administration of this, to CMS, probably can come down. They have a slush fund of a lot of money sitting there right now that they're not utilizing. Either use it and make our portal and some other things I'm sure we're going to get into a lot better, or reduce your fees, right? Let's cut down some of these costs and return some of this money that's been paid into this fund that nobody's utilizing. Return it back to the employers, return it back to the insurance companies, return it back to the physicians. It doesn't look like we have any plan to use any of that money. Let's just return it back to everybody who paid into it. We overcharged, we guessed, we were wrong. Let's return the money and let's lower the fees to make it easier.
Great. And Patrick.
Yeah, I think one thing that's really important on this point, so HALO represents about 20,000 physicians throughout the country. We are the largest initiator of disputes in the arbitration process, which a lot has been made of lately. But what folks don't often understand is that 77% of the physician groups that we represent employ fewer than 50 physicians. Right? So when you look at the public use files, you look at the data, and you see some large groups with large administrative backends able to utilize a complicated, expensive process, and then you see us. When you see us, you see these small groups. If you wonder where the small providers are who need the IDR process because the initial payment they received from the payer was $1 or was 75% of the Medicare rate, that is what HALO is taking to the arbitration process. And when you see the 85% win rate that providers have seen in the public use files, what you're not seeing is, like I mentioned, a 26% rate of default on the payer side. Additionally, a 9% rate of offers from payers of less than $1. So when you add those things together, and then add that about 25% of our data shows that there is no supporting evidence submitted by the insurer, after you've already filtered out the ones I've already mentioned, you get to a point where 50% of the time there is no actual effort being made on the part of the non-initiating party within the arbitration process. That is what is making this process expensive and cumbersome and non-functional. If there was a willingness to engage, as the law was intended to do in the first place, that's why the open negotiation period exists, right? So that we can resolve these things without going all the way through arbitration. Then you would see a significant improvement in the way that the process functioned. But it takes two to be a part of the process, and more often than not, we are the only ones at the table. And I do want to hit on one other thing. Again, pulling back to having to get this right for the patients first. I mentioned at the top, we have seen a significantly worrying number of instances in which patients are receiving, or at least at a minimum, physicians are receiving updated remittance advice documents telling them to bill the patient an amount that is illegal under the NSA. That should be the most concerning thing that gets discussed on this panel today. And it's exactly why Dr. Murphy's legislation exists. It would first and foremost create parity in the penalty structure for patient-facing violations of the NSA. If that is not an acceptable penalty, if there is a reason that insurers shouldn't be subject to the same penalties for patient harm that providers are, I would love to better understand why that's the case.
So let me start here with you, Dr. Brigham. I think we've heard today that under the NSA, IDR was intended to be a backstop, right? And now it's a central feature, right? It's sort of the centerpiece now. Is it your opinion that this process is being overused today? And kind of just to stack on that, another question here. If there was one thing that you could change about the IDR process tomorrow, magic wand, either operationally, statutorily, what would that be?
It's a loaded question. All right, we'll start with the first part. Is it a backstop? I think we need to understand, and I hope and I'm going to try and go through it as quickly as possible, we understand where the 17,000 number came from. That number came from New York. That number came from a state in which emergency medicine was exempted from the arbitration process. Emergency medicine, at least initially, accounted for over 50% of all of the claims that were put through the system. So the New York model was not the model anyone should have looked at. You should have looked at Texas. We were the model to look at, right? And had they estimated based on Texas numbers, the number would have been 1.5 million estimated claims that were going through the process. Well, that would have been back in 2018. Today, the numbers are now, as you heard, exceeding 2 million, and that's certainly as a result of people becoming having an understanding of the process, better having knowledge of which claims are eligible or not eligible, and deciding to participate in the process as opposed to some major change in the system. But I think it's important to understand that the 17,000 is just not a number we can anchor on. It's not a real number. It's a number that was just a poor estimate done by the administration. The second thing, I'll give Patrick credit for this, I saw him post it a while ago, maybe about a month ago on his Substack, is a discussion of how many claims are actually going through the arbitration process, just so that we understand, because I don't know what a definition of a backstop is, but I'm going to give you some numbers that he came up with and I have every reason to believe are accurate. Roughly 6% of all claims are ultimately going through the arbitration process. 6% of eligible claims are going through the arbitration process. 94% of claims are not going through the arbitration process. Of that 6%, another 20% are ultimately determined to be ineligible. So that number drops down around 4%. If you look at the data that I have, and I'm not going to use the data that EDPMA has put out, which says that roughly 60% of claims are not paid within 30 days, I'll tell you the data that I hear from independent physicians is roughly about 30% of claims are not paid on a regular basis. I mean, not paid at all. I'm not talking about not paid in 30 days, just not paid. Right? So if you took 70% of that 4% number, you're now down in the 3% range, right? So 3% of all claims are actually going through the IDR process. So when we say it's not a backstop, I feel like 3% is a backstop. What would I change? I'm going to say something that nobody else probably on here is going to talk about because I'm pretty passionate about it. We've got to change this cooling off period. It is an absolute disaster, okay? Cooling off is being used as a weapon to not pay. And that's it, as the bottom line. There's a 90-day window where we're not allowed to submit claims, but the problem is the wording is very vague. It says same parties for same or similar procedures or treatments. Well, as a surgeon, I use the same or similar codes and treatments all the time. As an emergency medicine physician or as an anesthesiologist, we all use the same procedures and the same treatments. When we say same parties, do we mean this employer who uses a TPA, or do we mean Blue Cross Blue Shield? And the problem is there's big disagreement there. And some of the non-payment or a significant component of the non-payment is coming from some disagreements about this cooling off period. It's very, very difficult to administer because it's a very nebulous term. We've either got to really tighten up the definition so that we can track it, or we just have to get rid of the whole thing together, because the reality of it is, as of right now, there's not a lot of negotiating going on between the individual physicians and the insurance companies during that cooling off period. It was a great idea. A great idea. It just isn't practical, and it's not happening. There are other ways we could solve this problem without delaying the ability of claims to go through, and I'm hearing from some groups, some doctors, that claims are sitting for over a year in what's called perpetual cooling without the ability to actually file the claim. Those are serious problems with the way we're administering it. So I know that people are going to talk about some other pieces of it that I think are really critical and important, but I think it's important to get out the cooling off period.
So very quickly, I want to just go over to the plan side and get your perspective as it pertains to that question.
All right, so I want to address first a few things because you brought up Texas. I don't know if any folks here are from Texas, but if you ask any employers in Texas, they will tell you that IDR is costing them more than 5% on their trend a year right now. So Texas is actually right now the most expensive state in the country when it comes to IDR. I also think that, you said it should have been modeled after Texas. Texas doesn't have QPA. A lot of the No Surprise Act, it wasn't just saying every single case, technically that could be a surprise bill. So every ER case, every radiology case, that should be a surprise, Gil. There was a lot that was built into the No Surprise Act to prevent that from happening, to actually make it a narrow backstop. For example, you have to negotiate. If you don't negotiate, you can't proceed to IDR. Another example is, again, you need to anchor the award to the qualified payment amount. The intent was not that IDR entities would be awarding, again, $200,000 spinal fusions. That was definitely not the intent. And the intent was that anchoring would bring costs down and actually would bring providers in network. And the cooling off, the idea behind the cooling off is that IDR should not become a primary payment pathway. That's the idea, right? We don't want providers to literally submit every single case into IDR. And so they said, you got to cool off. If you get a win, you have to wait 90 days. You have to negotiate with the provider. So there was a lot of thought that went into that. I think, and I actually like that you brought, I read your Substack also. So, and I did some math actually. So I looked at the 19.7 million cases that technically would qualify as in-scope cases. We pay, on average, more than $7,000 per each of these IDR cases. If you do the math on your calculator, what's $7,000 times 19.7? It's over $100 billion. So here's my question. Did Congress intend to add over $100 billion to American healthcare costs? I don't think so. And I think if you ask the question why we are where we are, and we could debate, some of the numbers, but I think most people would agree Congress did not intend for it to be as big as it is right now. And if you ask why we are where we are, I think a lot of this stuff comes back to incentives. Right now, providers win 88% of the time through IDR. And I mentioned they're getting through IDR more than 8 times what they would get in network. And when you're a provider and you're looking at this situation, you see, well, I could submit it, I could either come in network or I could go out of network, I could go through IDR, I'll win almost every case, and I can basically get whatever I want because these awards are not being anchored to in-network rates. What that effectively does is it creates what I would call a gold rush. That's what we have right now. It's a gold rush. And you have webinars from vendors, you have conferences that are trying to teach providers how do you use IDR to make more money. And we're not talking about making what another academic makes. We're talking about making 10, 20, 100 times more than what you're being paid right now. And, vendors then come in and say, we'll help you. This process is very complex. We'll cover the fees. We'll make it easy. More providers sign up. The cases continue to climb, and we're seeing actually in 2026, just a few months into 2026, the volume is already 30% higher than the last quarter of 2025. So it's exploding right now. And there's this also ratcheting effect. So what ends up happening is if you are a physician and you ask for a certain amount of money that is nowhere near market rates and you win, you notice that the IDR entities are not basing their decision clearly on in-network rates. And so the incentive there is actually to ask for more and more and more. And we see this across markets. We see this across specialties. We're seeing this across procedures. I'll give you an example. Largest practice in Connecticut, billing through IDR right now. It's a plastic surgery practice. One of their top procedures is breast reduction surgery, which I mentioned is the #1 highest grossing IDR code for us nationally. It's also was featured in the New York Times article a few weeks ago. And this practice in the beginning of 2024 was billing around $70,000 for this procedure, which Medicare again pays around $1,500 for. The average commercial payer pays somewhere between $2,000 and $5,000. They're billing $70,000 and they're winning. And they look at this and they say, if I'm getting $70,000, clearly it's not anchored to in-network rates. Why not ask for more? And so the beginning of 2025, this practice, and I'm not, this is not an outlier. This is a very large, the largest in Connecticut that's using IDR. They raised their ask from $70,000 to $138,000. And they continue to ask for more. By the end of 2025, they raised their ask to $220,000. And by the way, that's the primary surgeon. There's also a physician's assistant. And so that physician's assistant is also billing and asking for $220,000. So this code that commercial payers, this planned procedure, again, this is not a surprise bill, planned procedure that commercial payers are paying roughly $5,000 for dramatically higher than what Medicare pays. And also, by the way, a service where there's plenty of in-network options in Connecticut, they're asking for $500,000. So that's where we are right now. And so, to the question of why is this happening, it's happening because, we are rewarding these outcomes. In terms of the fix, I actually think the fix is very simple. And I think a lot of people here want to make it seem as though this is very complicated and it's hard. And I know the No Surprise Act took years to develop. The fix is actually very easy. The fix is basically anchor decisions to market rates. And if you don't like QPA, you don't need to use QPA, but at least a range. Give me an argument why a plastic surgeon should be charged $500,000. Tell me why a neurologist who remotely is monitoring a spine surgery should be paid $60,000, okay, when the spine surgeon in the operating room is paid $5,000. How do you explain that to an employer? I think it's very challenging. And so I would just continue saying, like, if the argument is independent physicians should be paid more, why are they asking for an average 8 times what their peers are paid? Why are they asking for, in many cases, over 100 times? So I think we've got to anchor the awards to in-network rates. I do also just want to follow up on some of the other comments, the allegations that were made against payers. And I heard a few things. One thing I heard is, these $0 payments. Actually, before I go there, we all need to follow the law, period, end of story. And I would say that for providers, I say that for vendors, I say that for insurers. We have to follow the law. On the $0 argument, one of the things that people actually realize is that around 40% of cases that are coming through IDR right now are actually technically out of scope and ineligible. If there's a case that comes in that is not in scope, it technically is not covered under the No Surprises Act. And insurers, by the way, in these cases, they're not paying $0. They paid the provider initially. They paid an out-of-network rate initially. And they're not going to pay an additional amount for a case that doesn't qualify. That doesn't make any sense. And so, it's interesting to hear in a forum like this about these $0 cases. I would love to see the examples, the actual examples, and let's look to see whether they actually qualify for the No Surprises Act. On the allegation that we are adjusting claims, again, the law is that if it's federal surprise billing eligible, we should not be adjusting claims. It should be based on the QPA. That's the law. We should follow that. We do. And again, probably many of these cases where you're seeing adjustments are not federal surprise billing covered. We've seen, again, 40% are being challenged as out of scope and ineligible.
And thank you so much for that. So as far as time here, I think we've got about 5 more minutes. I want to swing back over to Patrick, and just kind of land in the plane here a little bit. As far, let's assume Congress is not going to rewrite the entire NSA, but what are targeted legislative fixes? A fix, maybe a few fixes that could be done that could get bipartisan consensus. Again, our favorite word of the day, here in Congress, and actually, what would then be a measurable indicator, a good KPI to say, okay, you know what, things are in fact moving in the right direction?
Yeah, so there is one piece of legislation related to the NSA that's been introduced. It's the Murphy Bill. It is the NSA Enforcement Act, and it has broad bipartisan support in both the House and the Senate. And that is one piece of legislation that absolutely should be on the agenda to move as quickly as possible because, again, primarily it closes the gap in enforcement related to patient-facing harm. And then it also creates very real liability for payers who refuse to pay in following arbitration. You do those two things, and again, you've put the patient forefront, right? The first purpose was to protect patients, so you've prioritized that. And then second, you've reinstated the intended incentive around networking that comes with having to pay after you lose an arbitration. You do those two things, and I think the meaningful measures of success that you're likely to see is that I won't be able to bring with me a stack of examples in which patients have been harmed through payer noncompliance. And you'll see an increase in network arrangements after arbitration because, again, that incentive has been restored.
Great. And Garrett, over to you. Close us out.
Thank you, Shane. I appreciate it. I was getting a little antsy there, so, but I appreciate the opportunity. I think for employer plan sponsors, I'm going to be a little provocative here like Dr. Brueggemann was and bring up something that we haven't yet talked about. I do want to say, categorically at this point, we think that Dr. Murphy's bill is premature and would cause other problems and other complications for how the stakeholders would interact with the existing system. So we want to have that conversation, but I don't think it is ready to go as it stands today. So we would oppose that. But for employer plan sponsors, my employers look at and have believe that the fundamental flaw and the thing that Congress could address in the No Surprises Act is actually the payment structure and the utilization of the arbitrators. The IDREs are paid on a per-case basis. There's problems with ineligible claims, as we've already discussed. But even for eligible claims, even if we get away from solve eligibility, for ineligible claims, the arbitrators will always have an incentive to skew their decisions in favor of the providers so that they themselves, as businesses, can get more revenue. Otherwise, their revenue is going to be flat or decreasing in alignment with the objectives of the No Surprises Act. If you need to get people in network, that naturally will drive down the number of claims going into arbitration. So we think the fundamental flaw is actually the arbitration. And something that didn't exist at the time of the No Surprises Act that is a credible resource that we should be availing ourselves of is the transparency and coverage files that were required in 2020 coming out of EBSA, so the Employee Benefit Security Administration under ERISA. Plan sponsors are reporting out on a monthly basis the amount of paid in-network claims, and we can utilize those files as a reference point, instead of wasting all of this money on arbitrators. And those files, if we structure a calculation derived from those files in the right way, balancing the priorities, because I'm just going to be honest here, we don't want our carrier partners also manipulating networks to drive people out of network artificially just to drive down the costs, because that artificially games it. We want a robust marketplace of in-network negotiations. We want access. We want affordability. We want our patients to be able to get our employees and their families to be able to get the care they need when they need it. And I think just siphoning off to the IDREs is a waste of resources that can be solved with complicated, in need of work data files, but I'd rather have a complicated data file issue and how to make a calculation than fight persistently against that conflict.
And thank you so much for that. Again, thank you so much, Congressman Bean, for having us here. Thank you so much to the staff. Thank you all for tuning in. We didn't reach the promised land of consensus today, but you know what? I think we're all in agreement that we are going to stay on the path to reach consensus. So thank you again so much, Congressman. Really appreciate it.
Shane, thank you very much. And to our panelists, I need all to come out front. First of all, I think it's no surprise that y'all rock this panel. That's what I'm saying. Come on out. I've got a special gift on behalf of everybody here. We all chipped in and got you a little something, Shane, and to all our panelists, thank you so much for the debate. Come on out. Let's take a pic and before we move on to our next panelist. Well done, Doctor. Good to see you. Thank you. Congratulations. Hey, Garrett, well done. Ariel, you did super, which is good. Doctor, it's good to see you. Shane, thank you so much. Let's come out right there. As we get our picture ready, I got something special for each of you, and that is America turns 250 years old. And so how about some America turns 250 years old birthday cake flavored lip balm? How about that? Everybody gets one right there. So let's hold this right here. We'll get a pic for everybody. That's exactly right. You'll remember the day you earned it. You weren't given it. You earned this lip balm. Let's take a pic here. Here we go. Thank you so much, panelists. Thank you so much, Shane. Well played. Absolutely. Thank you. Well done. We all know the arbitration process needs some tweaking. Both sides agree on that. A big thank you to Chairman Jason Smith of the Ways and Means Committee for allowing us to use the Ways and Means Committee room. It's kind of a big deal that we're here. We also want to say thank you to the Ways and Means Health Subcommittee staff. Yeah, if you're a panelist, come on up. I'm just filling time until you get ready to go. To the Ways and Means Subcommittee Health staff, many are in this room, and those that aren't in the room, I know you're watching on our live stream right now. So thank you, panelists. Doctor, well done. Thank you very much again. Thank you. Ladies and gentlemen, welcome back to the Pathway to Consensus series. We're live on Capitol Hill talking about ideas to make healthcare affordable, better, accessible, and sustainable. So ideas, we just had the No Surprise Billing Act discussion, but now we're going to get into prior authorization. Now, one side will say it's a valuable tool. Prior authorization, a valuable tool for managing ever-increasing health costs. The other side will say it's just an obstacle that is put between the doctor and the patient, the vendor and trying to deliver care. So what's this all about? Well, we've got another all-star panel that's going to liven things up with healthy debate and trying to get to the bottom of what we can do better or how we can make that change. I've got my great friend, I've already introduced her, Mary Mayhew, who is the former director of for healthcare in Florida. Secretary Mayhew is what I still call her because she was a big deal. She's still a big deal with the Florida Hospital Associations. But our moderator for this panel is a gentleman that is well known on Capitol Hill, having served for the health fellow for the Energy and Commerce Committee, as well as working healthcare for Congressman Bob Latta of Ohio. Today, he is the federal government affairs director for a company called BioMayoru. And so, ladies and gentlemen, our moderator for panel number 2, who will introduce our all-star panel, please welcome Mr. Paul Hartman. Big Paul.
Congressman Bean, thank you very, very much. First, before I start off, I've got to say, you have to stop having Shane Wood's panel go first, because it is extremely hard to try to top that. They absolutely brought the energy. So good afternoon, everybody, and welcome to today's discussion on prior authorization. I want to thank both Congressman Bean, who always brings the energy, and his wonderful staff, Richie Lemura, for inviting us to participate in today's health series. By way of introductions, my name is Paul Hartman, and I'm the Federal Government Affairs Director for BioMayoru, which is a global in vitro diagnostic company that specializes in respiratory and infectious diseases. We actually have a pretty big footprint in the great state of Florida, and particularly the 4th District, which I might say is the best in the state, where we ran close to 170,000 tests in 2025. I am absolutely thrilled to be here with you guys today, especially on a beautiful late Friday afternoon. So, we are honored to have with us representatives from 2 pivotal pillars in American healthcare with us, AHIP and the Florida Hospital Association. So let's get into a little bit of background into the history of prior authorization. So to understand where we are, we're going to have to look back. So prior authorization began in the 1960s as a pre-certification, a tool used sparingly to justify extended hospital stays and high-cost surgeries. By the 1990s, with the surge of managed care, prior authorization became a staple of utilization management, designed to ensure care was evidence-based and to keep healthcare controls from spiraling out of control. Over the decades, however, what started a targeted safeguard has expanded into nearly every facet of American medicine. Today, it covers everything from basic diagnostics to prescriptions, moving from a niche administrative check to daily operational reality for every clinic in the country. So where are we today? We stand at a critical crossroads in 2026. On the provider side, physicians report spending an average of 13 hours per week on prior authorization paperwork, often citing dangerous delays that lead to treatment abandonment. On the payer side, our insurers maintain that prior authorization is one of the few effective tools for managing medical waste and catching unsafe treatments before they reach the patient. However, the tide is turning towards simplification, As of this year, we have entered a new era of accountability. Impacted payers are now mandated by CMS to process urgent requests within 72 hours and standard requests within 7 days, while providing specific, actionable reasons for every denial. In April, the Trump administration proposed to extend similar timelines to prescription drugs as well. Insurers have put forth new commitments to improve the prior authorization process for patients and providers. For example, some insurers have already begun voluntarily reducing prior authorization volumes, some by as much as 30%, and gold carding programs are recognizing high-performing doctors to remove these barriers entirely. So, the future. We have to axe the facts. So looking toward 2027 and beyond, the goal is a fully digital, transparent ecosystem. We are moving towards a real-time electronic prior authorization through standardized APIs with a target of approving 80% of requests instantaneously at the point of care when all needed information is provided electronically. With the proposal to extend these protections to prescription drugs, we may finally get to axe the facts once and for all. Today, we will dive into these tensions. How do we balance the clinical integrity of the doctor-patient relationship while ensuring both high-quality care and the financial sustainability of the entire system? Please join me in welcoming our panelists as we explore the pathway forward. First, I'd like to introduce Jeanette Thornton, who is an Executive Vice President of Policy and Strategy at AHIP. In this role, she oversees AHIP's policy development for all insurer lines of business, including Medicare, Medicaid, the commercial market, and clinical innovations. She has significant health policy and government experience and is one of the country's experts in health insurance legislation, regulations, and operations. Since joining AHIP in 2006, and congratulations on recently celebrating your 20 years, she has led public policy-related employer and commercial health insurance markets, as well as initiatives and research on many challenging and high-profile issues, including legislation to end surprise medical bills for patients, which the Ways and Means Committee was very active on. Next, I'd like to introduce Mary Mayhew, who is the president and CEO of the Florida Hospital Association. She joined the Florida Hospital Association in October of 2020 and has focused the organization's efforts to the delivery of healthcare to support a modern, sophisticated system that can respond to the evolving needs of Florida citizens and visitors alike. She has proactively led on Florida's mental health system and to improve the care of older Americans while enhancing efforts to expand pediatric care as well. Prior to joining Florida Hospital Association, Mary served as the Secretary of the Florida Agency for Healthcare Administration for the Governor Ron DeSantis. As Secretary, she played a huge role in the COVID-19 pandemic and improved health outcomes for more than 4 million Medicaid enrollees. Thank you both for being here with us today. Before transitioning to our questions, do either of you have any brief opening remarks that you'd like to address on today's topic? We'll start over with you, Mary.
Well, thank you. Congressman. All right. Good afternoon. Happy Friday. Congressman, again, thank you. As everyone has said, I think it's a pleasure to have this type of a forum. 5 minutes is rarely enough ever for me, so love the extended ability to talk about this. And I'd say, as it relates to prior authorization, we have a moral imperative. This has reached such a burning point, a boiling point in our healthcare system. When we look at the challenges that clinicians face, it's leading to burnout at a time when we're already confronting significant workforce shortages across the country, and certainly in Florida, we have a rapidly aging baby boomer population. The demand for healthcare services and the ability to support timely access to those services is critical. Right care, right time, right setting. What I hope that we can talk about is the alignment. There's a lot of really great, positive, forward movement. At the end of the day, it's going to be the practical, boots on the ground reality of whether or not it is being seen visibly by clinicians, by case managers in hospitals. I convened a call this week, last minute, had over 85 people on this call from around the state of Florida. They did not suggest to me that they were seeing a lot of progress in prior authorization. The number of individuals who are stuck in expensive hospital beds that no longer require hospital level of care. Of the 40% of the hospitals that respond to a survey, it's over nearly 500,000 in preventable hospital patient days, with the biggest contributing factor being the lack of timely authorizations. And again, a lot of this is how we help people get to the right next level of care. I heard myself recently out loud trying to explain to my sister the 3 midnight rule as we're dealing with my 93-year-old mother who'd broken her hip recently, has advanced Alzheimer's, and just trying to translate what is such a complicated structure when people just want to make sure that they're able to have that relationship with their patient, between the patient and the physician, and that medical advice can be acted upon. What I hope that we can focus on is exactly what you laid out. How far have we come in the standardization of medical decision-making based on decades of evidence-based research that are supporting protocols that really call into question the necessity today of a lot of the prior authorization that is still used? Just imagine if, as a stroke patient, and you're languishing in a hospital bed, you no longer need to be in the hospital, you need to be in inpatient rehabilitation. And that authorization is not coming in a timely way. That's what we're talking about. These are human beings, the care that they need. I'm very optimistic and excited about the announcements that we've been seeing, the pledges, the voluntary commitment. But we've got to drive this with a sense of urgency for the patients, for the physicians, and for the opportunity to dramatically reduce preventable administrative healthcare spending.
Thank you, Mary. And we are thinking of your mother during this time as well.
you.
So, Jeanette?
All right. Hello. Thanks for having me. My lips are chapped, so I'm really excited about getting the lip balm later. So, look, sorry. Well, it's great to be here and talk about prior authorization and the work that we're doing to really streamline, improve, and modernize it moving forward. I think you're going to hear a lot of alignment between Mary and I and how we could take advantage of technology to really improve this process moving forward. So, on evidence-based care, we recognize that the majority of physicians practice evidence-based care and care consistent with that. But we are all very familiar with the variation in clinical practice as well as prevalent low-value and wasteful care that still occurs. Prior authorization is really an important tool. It's got several really important uses. Care must be evidence-based. Mary talked about that. We want to prevent wasteful or harmful care. Affordability, we talked about that on the earlier panel. It's very important to promote. We want to make sure that patients are going to the lowest cost locations and combat fraud. But we know, and I hear you, Mary, that this can be frustrating for patients and providers, which is why our industry came together last summer on commitments with CMS and HHS to really improve the prior authorization process. We had nearly 60 plans representing 260 million covered lives come together and say, we are here to improve this process, and we've committed to publicly report on our progress. Plans looked at opportunities to reduce the volume of the prior authorization that they use, and our data shows that that will result in 2026 in an 11% reduction in prior auth. We committed to honoring existing prior authorizations when people changed plans to ensure that there was that continuity, and we also committed to improving our communications about prior authorizations. No one wants to get a notice that they can't understand. Several more commitments take effect next year. We committed to adopting modernized e-prior auth standards and getting to, as Mary mentioned, 80% of approvals in real time. What's real time? Getting a decision in seconds, not days. That'll really address, Mary, the issue that you raised about people in hospital beds. But this is going to require us all to work together. We're going to need providers to adopt this technology. We're going to need the vendors to support us. And we are really needing to throw away those fax machines. We don't want any more fax machines in healthcare. So I do think this work that we're all doing together is really going to turn prior authorization from a source of friction to that trusted patient protection that it really was meant to be. So I look forward to the discussion, Paul.
Thank you very much, Jeanette. So I think that's a good segue. In your opener, you mentioned that prior authorization is an important tool to avoid waste. Now, Mary, prior authorization was designed for safety and cost control. Has it evolved into a necessary clinical safeguard or a primary administrative barrier?
From the clinician perspective and everything that we keep hearing, and again, I want to acknowledge this, the alignment that we've got to keep focused on. Do we share the same goals around using this to ensure medical necessity? And as we come back to looking at some of the case examples, we've got to understand whether or not the compliance is there, which is where public reporting, voluntary reporting at a granular level will be really helpful. But when we hear from oncologists, where, again, the clinical decision-making around cancer care is so standardized, and yet they're dealing with burdensome prior authorizations, and again, and the stress. Advanced imaging generally. Do we have adherence to the protocols, and therefore are we still dealing with unnecessary administrative burden that doesn't seem aligned with medical necessity? Variability should be part of the challenge of where prior authorization is used, the exception, not the rule. And I'll say, too, that when we look at the efforts to reduce prior authorization, part of the concern that we're hearing is, will it be on the higher cost services? If it's on labs, that's great, but are we still dealing with some of the challenges? When we look at individuals who do need post-acute care, the higher the intensity of their post-acute need, like long-term acute care hospitals, the longer they're staying in our hospital waiting for that prior authorization. So public reporting and understanding the data and what the data speaks to, just as we report on quality data, that will allow us as an industry to advance that alignment around, is this being used to address appropriate clinical decision-making? And again, I love what Jeanette said. I mean, when I think about Amazon knows what I want before I know it, right? In this day and age, how do we increase that timeliness, that immediacy of the responsiveness with all the billions of dollars we've invested in electronic medical records, in technology designed to support that effective clinical decision-making and the payer response to the requests?
Thanks, Mary. Jeanette?
Sure. So I think it's important to level set that the vast majority of claims aren't subject to prior authorization. So we have to sort of look at, we're talking about a much smaller universe here. It is a real important clinical safeguard. I understand what Mary is saying about us wanting to get to where we're all practicing evidence-based care, but I think we've all seen examples of where that is just not occurring today. I think many in this room have seen all of the stories about the horrific levels of fraud with Medicare skin substitutes in Medicare fee-for-service. Patients were harmed by this, and that wasn't a problem in Medicare Advantage because those plans were using prior authorization. So there are really critical examples of where prior authorization is extremely beneficial to the safety of the patient. But what we're talking about here is the need to make it easier, make it invisible so it happens behind the scenes without anybody really realizing that it's not a burdensome process, using data directly from the electronic health record. So this is not a separate website, a separate portal, a separate question. And it's really part of the workflow so that this can be done very quickly and seamlessly, and you have the information and the answer right away, and you can move on and make some decisions about next steps.
Thanks, Jeanette. So I think that's a good segue to our next portion. So Mary mentions that higher costs and burdens can be a direct result from prior authorization. So the economic trade-off, insurers argue that prior authorizations keep premiums low. If prior authorization were eliminated tomorrow, what would be the immediate impact on the average consumer's healthcare costs?
Right, absolutely. We would certainly see an increase in premiums if prior authorization were eliminated tomorrow. Milliman looked at this issue for Blue Cross Blue Shield Association and found that if prior authorization for the commercial market went away, a 5% increase in premiums. We have other examples. The California Medi-Cal program temporarily suspended prior authorization for prescription drugs while they were making some upgrades to a new system. They immediately saw $179 million in fraudulent payments when that was suspended. So it's really playing an important affordability role in ensuring that people can access their care on time, but we're making sure we're getting them the right care at the right time.
Yeah, I'd like to respond to that. So there are some, obviously, lots of different data, dueling data, but some interesting estimates of over $35 billion spent annually on prior authorization, administrative expense, both on the insurer side and on the provider side. It just, as we look at our affordability challenges, the sustainability of the healthcare system, the imperative to not just sustain it, but to continue the modernization, just what we're talking about now, the improvements in technology to respond to the opportunity to integrate in the electronic medical records. That's going to take resources for hospitals to invest in, but and importantly, I'm very concerned about a lot of the physician practices and their ability to have the electronic medical records and the sophisticated technology. The opportunity to reduce some of this preventable administrative expense is critical to sustain the kinds of investments we want in technology, in clinicians, in recruiting the best and the brightest. On top of that, we have a physician shortage in the United States. So I spoke with a physician in a rural hospital playing multiple roles in the emergency department, in the hospital. The degree of stress and anger and frustration and fatigue that he shared with me about his interactions chasing authorizations. His story is playing out over and over again. So I think I hear you that there may not be the volume of care subject to prior authorizations, but the level of anger and frustration would suggest that there's a level of prior authorizations for the services. When we think about 20% of the population account for 80% of the spending, that's where we're still dealing with the vast majority of friction. Again, taking clinicians away from delivering healthcare services to be on the phone, chasing the authorization. So I think we've got a real opportunity here both to improve that patient-physician relationship, the timely access to care, and to reduce that administrative expense.
Thanks, Mary. So we talk about the economic trade-off, but let's focus on the most important, depending on it, which is obviously the patient and patient access. So treatment abandonment. This is for you, Mary. So with 82% of physicians reporting that prior authorization leads to patients abandoning treatment, are there policy guardrails needed to protect the vulnerable populations?
100%. And, I remember doing an interview with a reporter recently, and we were talking about this, and she said to me, her physician, when care was denied, the authorization was denied, her physician practice said, we don't have the ability to chase this authorization. So a real clear example in that case that she was not getting the care. Countless stories of individuals frustrated not getting the access to the MRI, to the CAT scan, and they're just going to the emergency department and demanding access there. there is no doubt that people are walking away. They're frustrated. They're angry. We've got to, again, I go back to our opportunity to look at data, to have public reporting. We're going to have a better sense of this. We just don't have access to it at a level that we need to better inform how much of this is undermining timely access to medically necessary care.
Now, Jeanette, what are plans doing to achieve faster response times to avoid abandonment?
So we as health plans, we don't benefit when someone goes to the emergency room and they shouldn't. We don't benefit from someone delaying evidence-based care. And so absolutely we agree that the decisions need to be faster. And this is why we've done the things that I talked about earlier, Paul, in terms of really supporting new standards, making sure that this can be done electronically. We get 47% of all prior authorizations today via phone and fax. 47%. Of course you're going to have to chase something and call somebody back and have a missing fax or something that you can't quite read if we're getting 47% via fax. And so we need to work together to eliminate those and get to a process where this process can be used with data that is sent electronically. We're getting complete information the first time, so you don't have to call us up and say, what's the status of this? And the other thing that the industry has come together to do is to agree that we're going to collect the same set of data for the same procedure. So a hip replacement, we're all going to agree that we're going to collect the same underlying data so the provider doesn't have to go, oh, it's different for Plan A versus Plan B. We do think that consistency will do a lot to reduce the burden and the burnout issue that Mary talked to earlier. So I think we agree that we have to be faster, and I do acknowledge that this work underway by our industry in partnership with providers will really put us towards that goal.
Congressman Bean, I'm going to mimic my buddy Shane Woods here. It sounds like we're getting some consensus and some agreement upon each other right now.
You need to sing.
I don't have the beautiful voice like he does. So this next part will lead to the diagnostic portion, which is near and dear to myself. Delays in advanced imaging can postpone life-saving diagnosis. Should diagnostic care be subject to different prior authorization standards than elective treatments? Mary?
Yeah, I think that's exactly where the data, the research, and the information have to come into play. Again, we've got a lot of data. Are we using that data to inform decision-making and standardization? If the vast majority of those requests for imaging are being authorized, then inevitably the question needs to be, is the authorization necessary? What is the clinical documentation that over a period of time would demonstrate that especially when we're talking about oncology care where it's well established, there are a host of evidence-based protocols involving that imaging that if it's well established, then is that prior authorization necessary? We've got shortages in allied health professionals, in imaging technicians. We've got to look at ways to streamline so that they're not both dealing with the delay of the authorization that is further compounded by the delay in access because of shortages.
Jeanette?
Sure. So a couple of things here. It's really, really important that and it's a core foundation of how plans make decisions around where to use prior authorization, that it is used selectively. And all of our plans that signed on to the voluntary commitments really looked at their prior authorization lists and made some decisions as to where, exactly to Mary's point, where it would no longer be necessary. And so you did see a number of companies decide to remove certain prior authorizations, and that included some high-tech imaging areas as part of those recommendations. At the same time, we still see a lot of variation in cost and quality in terms of what is the most appropriate site of service. Is it appropriate? Is an ultrasound appropriate here? Is a CT scan appropriate here? And prior authorization does play a really effective role in helping direct people to the right site of service to ensure that our premiums can stay affordable. And there's also just the underlying issues. You don't want somebody to be overly exposed to that amount of radiation unnecessarily. And so There needs to be some check and balance in the system. Mary, we acknowledge that most physicians are practicing that evidence-based care, but we still see the stories where that's not the case. And fortunately or unfortunately, depending on what side of the table you sit on, this still needs to be in place to ensure that those checks and balances occur, with the important caveat here that we want to make this simpler, more standardized, and easier for the physician and their staff to get done, so there aren't any barriers to care.
And I would just say to that, I think part of our challenge often is we paint with a broad brush. Mm-hmm. So, how do we both allow for the kind of scrutiny and oversight for where the care is not supported by the medical evidence, where there's too much variation, as opposed to the vast majority of the field, which is complying with evidence-based, standardized protocols. It's different. I recognize for the industry to have that kind of surgical approach to that, focusing in on where the outliers are. But that is, again, from an efficiency, from the benefit of the patient, the more that we can drive, which again, I think the standardization across the industry on criteria will go a long way, and transparency around that.
Thanks, Mary. So, Jeanette, prior authorization is commonly required for growing class of GLP-1 medications. Why is that the case?
Yes, good question. Well, a couple of things I'll say on GLP-1s, and I think we all know this is just an amazing innovation. They have amazing potential, but unfortunately today the economic model and the price that is charged for GLP-1s is just not sustainable. We cannot sustain that level of cost in our country. And so that is a really important piece of it. But the other piece is and I think this gets lost, there are really important clinical considerations here. The labels themselves have specific qualifications around BMI and other, in some cases, comorbidities that should be present. And of course, the plans want to make sure that the drugs are being made available to those who need them. Even in looking at the rollout coming up here this summer of GLP-1s to Medicare beneficiaries, in that program, there are qualifications that people have to meet in order to qualify for access. So it's very similar to that program as well.
Thank you very much. So as we transition from the patient access portion to my favorite, the legislative and regulatory landscape, we want to talk about some new regulations. So, Jeanette, effective January 1, 2027, new requirements for EPA take effect for medical services. Can you talk about the impact of these new requirements?
Sure. So I promise I won't talk about FHIR and APIs because I don't think anybody really knows, including myself, what those really mean. No, I know what they mean, but really know what they mean. But what is really important for us to think about is starting in January for plans and federal programs, so that's Medicare, Medicaid, and the federal marketplaces, they have to support new prior authorization standards. And as I was speaking to earlier, these standards really mean that data will be pulled directly from the provider EHR and sent to the plan so we can get those decisions faster. And then as part of those commitments that I mentioned earlier, we all committed to also supporting those same standards for the commercial market. So that way, a provider who's seeing a Medicare patient doesn't have to do something different with their Medicare patient than their patient covered by employer coverage. So that was an important part of our commitments. We're also getting to the issue that we've spoken about already around faster response times as part of that.
Now, Mary, can you talk about how hospitals view these new requirements?
Yeah, I mean, the proof will be in the pudding. And do they experience it? Are they feeling it? And so far, this is where they still have a concern about what they're experiencing against the backdrop of these changes, these commitments. So, I'm encouraged by the industry driving this standardization across the industry. The level of complexity and confusion from plan to plan to plan just exacerbates this structure. So the opportunity both on the standardization and then this automation, I think in some ways we look at where we are in 2026, how is it possible when we look at the lightning speed of AI today and all of the revolutionary, transformative benefits on so many fronts. And it's just mind-boggling that the fax machine is still part of the equation. But that isn't necessarily just driven by the healthcare providers. I think they feel just as frustrated that it still feels like this very paper-intensive process. Not that they're driving it, but just somehow the process has not modernized. It hasn't kept pace with what we have today for information systems and infrastructure. I think we're rounding the corner, but we've got to be testing it out. Is it accomplishing what we expected it to? Are people experiencing that boots on the ground?
Got it. So I kind of want to talk about the gold card and its effectiveness. So 5 states and several major insurers have already implemented these gold cards exemptions. Is this a scramble solution, or does this create a new oversight risk?
I mean, I'll take it then. Jeanette may have more thoughts on this. We've had a patchwork quilt going on around the country with states introducing legislation on this. We've got a lot going on now federally between CMS, Seniors Timely Access to Care, other Medicare Advantage Improvement Acts, all driving at much of the same. The timeliness necessary for urgent authorizations, for non-urgent authorizations, and then the gold card, getting at this clinical standardization, evidence-based, allowing these clinicians to be free from. My understanding is there just hasn't been a lot of adoption of it by the insurers. Again, I'm not sure if it's on which side of the equation, but I don't know that it's had the adoption that we would have liked to have seen.
Jeanette, what are your thoughts on the gold carding?
Sure. I think gold carding can play a big role here. If you see a provider in a certain specialty that you're working with and they're consistently practicing evidence-based care, yeah, they should get that golden ticket and not have to do prior authorization. I think that makes sense. But you do have to continually look at it. And, another thing, we've been talking with our plans a lot about this, and a lot of these programs are built on the model, hey, if they're meeting consistent evidence-based practice 90% of the time, 95% of the time, you wouldn't really want to be the patient that's in that 10% or in that 5%, right? So there's sort of a push and pull there, but certainly, yes, a lot of our plans have been expanding their gold carding efforts, and I'm expecting more to come in that area.
So transitioning from the gold card to national standardization, insurers are working toward greater standardization of prior authorization process. Can you go ahead and talk a little about this further?
Sure, I'd be happy to. So I guess a couple thoughts here. I think we came to the table as an insurance industry and said, we want to make this process work better for patients and work better for providers. And as part of that, we heard a lot from the physician and hospital community who said variability in how things are collected and how things are done across payers does add extra time and burden. I shouldn't have to do it one way with one plan and another way with another plan when it's the same procedure. And so really have rolled up our sleeves, really looking and developing those standards in terms of what documents will be requested. And I do think it'll help us both accelerate more automation and modernization that we were just talking about, Mary, as well as helping aid and getting more instances where we get all the complete information the first time. Today, a lot of denials occur because we're missing information, there was a miscommunication, et cetera. We want to make sure we take those off the table and get things right the first time so that we don't have people having to wait for a decision because something wasn't complete.
Mary, how would the standardization improve the prior authorization process for your members?
First of all, I think it's long overdue. We've been talking about standardization on a number of fronts in healthcare for years. Those expectations exist on hospitals, on a number of clinical fronts. So I think this administrative aspect and the standardization is critical, and we need to really drive this to reduce, again, the expense and the complexity. I think some of this is about what the payers want. I hear too often it described as whack-a-mole. We give them the document they request, and then they turn around and say, no, we need X. And it just feels like a cat and mouse game. I think The extent to which there's more clarity, there's more standardization, that's true about clinical criteria. It feels often as though it's in a black box, and there isn't the level of transparency that helps to inform. Have we provided everything that they needed in order to inform? It also gets back at what Jeanette said earlier, though. The extent to which these decisions are being made on access to the electronic health record, and that process is streamlined, it should reduce this constant back and forth, which just prolongs the process and delays the authorization.
Got it. So other than the consensus, my second favorite word would probably be transparency, and I'm glad you talked about that. So for transparency mandates, what will be the impact by requiring insurers to publicly report each denial of these claims?
Well, our desire is that reporting gets down to a more granular level so that it is not just global authorizations and denials or approvals, but that by service lines we can actually drill down and better understand, again, to further inform future decision-making, future commitments. If we're looking at imaging, if we're looking at oncology, if we're looking at joint replacement, post-acute, we need more transparency on that, both to understand, are there legitimate areas of concern around variability, or are we seeing significant delays, for example, on skilled nursing facility level of care? If we are, then can we come back and have yet another consensus discussion about the why? Because I'll tell you from the hospital perspective, once the patient exceeds the average length of stay that their payment is based on, they're not getting paid anything more while that patient stays in the hospital and isn't getting the authorization for the next level of care. So no one is paying, but the hospital is still incurring the expense. So I think understanding through public reporting would continue to inform this kind of a conversation.
Jeanette?
So we have to do a lot of public reporting, and that certainly includes new data requirements that took effect at the end of March that requires a lot of data around prior authorizations and decisions and approvals, denials, appeals, all of those things. It's just important when we're looking at this data, it tells a lot of different stories, right? We've talked about this a little bit, but sometimes there is a denial because there shouldn't have been a prior authorization. There was missing information. It wasn't complete. And so that's a denial. And then there's maybe a legitimate denial, which was the skin substitute issue where you want us to be denying that service. So, all of that stuff is sort of jumbled together in those denial rates. But our plans are complying. We support transparency. And, I'm sure a lot of folks will be looking at that data over time here.
Love hearing that, which I think is a good portion to go over to the next section, which will be clinical integrity. So, specialist peer review. Should any clinical denial be reviewed by a doctor in the same specialty as the ordering physician? Mary?
Did you say, should there be an equivalent peer-to-peer engagement? Is that what you asked?
Yes.
Yes, it should. And again, Jeanette, you probably have a very different perspective or experience on this. I hear this so many times that the person on the other end of unfortunately still the phone is not in the same clinical field making the determination. Just the frustration for the clinician who's a neurologist talking to a family physician. So it could be that it's just these rare cases, but it doesn't feel that way in terms of the volume of complaints we receive. So, but the other concern that we continue to hear is that just as I'm referencing physician shortages, we're hearing about challenges with timely peer-to-peer review, that there's a backlog that is further exacerbating the peer-to-peer review.
Jeanette, to transfer over to evidence-based criteria, can you speak as to how insurers develop their prior authorization criteria for approval and ensure decisions are evidence-based?
Sure, Paul. It's a really important part of the plan role here to make sure that their medical policies are consistent with evidence-based policy. There's a lot of different sources of information that plans look to when they're setting their policy, whether that's the literature, the specialty society guidelines, other resources, professional society guidelines, and other things. So it's definitely a part of their process. Another thing that's really important is provider input through various committees and other forums. There's always changes in evidence. There's notices coming out from the FDA. There's changes to guidelines, and we're really work hard to keep up to date with all of those changes.
Now, I know everybody would love to spend another hour on a Friday afternoon in the beautiful weather we're having in the D.C. area, but I am getting the 5-minute warning right now, so I want to go to our last section, which would be consensus. If there was one aspect from each other that fundamentally you understand where the other is coming from, what would that be? Jeanette?
Sure. I mean, from the conversation today, I really understand that, delays are challenging, and I know that is why we've really focused on increasing the simplicity of the process, increasing response times, and really making sure that we're getting all of the information up front so we can make a decision and everybody can move on.
Mary?
Well, I've got about 45 more minutes in me, so I don't know what you're talking about. I think reducing the volume, improving the efficiency, and reducing the administrative burden from the resource intensity and the expense is going to make a significant difference for the patients and their relationship with their physicians and for the affordability of healthcare. We are on the right path in this pathway to consensus here, the work that the industry is doing, just the ability to see real-time data and information to understand, are we moving in the right direction? Are we seeing the outcomes we expected? If not, how do we regroup, reevaluate, where are the missteps, where is the disconnect, misalignment, and keep working on this in the best interests of patient care and the sustainability of the system?
Now you talk about sustainability. Where do you see the future developing on partnership between the providers and obviously the insurers?
Again, I'd say honestly around reducing variability, rewarding for outcomes. This is administrative friction to a great extent. I'm not saying that there isn't value to ensure that the care that's being authorized is medically necessary, but it doesn't feel like we're putting our time and energy where it is most needed today, which is we've got this rapidly aging baby boomer population. The demand on the system is going to overwhelm our ability to respond. Our hospitals today are operating at 100% capacity. We don't have adequate skilled nursing facility beds, home-based care, home health. We don't have primary care physicians. We need to be coming together and focusing on the continuity of care, the continuum of care. The more time we spend on some of this administrative friction, the less time we're able to focus on longer-term sustainability.
Jeanette?
I agree. I think it is important for us to focus on sustainability. And in the short term, though, it is really important that we will work together to get some of these systems implemented so we can have this much more streamlined and modernized process, Mary. And I know it's going to be a lot of work. We're going to have to test. Providers are going to have to change what they're doing. We're going to have to change what we're doing. But we think it's all for the benefit of the system as a whole, and then we can work on those other things together.
Loved having this dialogue with the two of you. I think the overall consensus that we can agree upon is that we need to axe the facts once and for all. Congressman Bean, thank you for bringing us all here together today. And
Paul,
thank you for your leadership.
Thank you very much, our panelists. Thank you. It was a great panel. Let me tell you what I did, and then I'm going to tell you what you did. I set the bar pretty high with expectations, and what the panel did is exceed them. How about that? So come on out front. We want to take a picture to commemorate this day. And yes, you'll never believe what we got you for participating. We got America Turns 250 birthday flavored cake, lip balm. Mary Mayhew, Secretary Mayhew, hooray! Well done. Come on out, Jeanette. Well done. And Paul, bam, struck the right tone. Let's get a picture right here. Thanks again, ladies and gentlemen. Thank you very much. And for, Paul, well done, my friend. Thank you. That's a tough, well done. You walked right in the middle, and we got work to do, ladies and gentlemen. This is Congressman Aaron Bean. We're in the Ways and Means Committee room. We're on the pathway to consensus. I want to thank the Bean team for helping put this together. Richie Lemura from our team is the lead on it. Thank you, Richie. We also got James Thomas, Alyssa Tu, Jamie Robinette, Stephen Moeller, our interns, Bella and Lauren, and I see Giancarlo in the back. So, ladies and gentlemen, if you have a thought or idea, or if you want to participate on the next pathway to consensus, reach out to our office. You got an idea. There's lots of work to do, and we hope to see you on the next pathway to consensus. Good night, everybody. Have a great weekend. Let's go get them.